باني
أهلا وسهلا.
يعطيك العافية دكتور.
الله يعافيك.
دكتور, I just made you a co-host now. You can start sharing your screen. Doctor, one more thing. The students are asking you kindly if you can share your lectures before starting so they can write notes with you.
I usually share with them an outline of the lecture, which I can send by email if you like.
Okay. If that will be okay, Doctor, then yes, please. Thank you.
Let me, just give me a second. I know it's...
خذ راحتك دكتور.
Who did you send it to?
Sorry, Doctor. You can actually send it to me, or if you want, you can just, if you open the chat box, there is a file button you can press and you can actually browse and send the outline here. Excuse me, Doctor, you're muted.
Can you hear me now?
Yes, we can now.
خلاص, are we ready to go?
Yes, Doctor. Thank you.
So good afternoon, everyone. We're going to discuss pituitary endocrinology, and we'll have two back-to-back lectures talking in the first one about hyperpituitarism and the next one about deficiency of pituitary hormones. So it's going to be a bit long. I wish they had separated it. This is how things are, I think, out of our hand. I welcome your questions. Anyone who wants to ask questions can either raise their hand and the moderator will let me know, or they can speak. We'll see how it goes. Right. Before we start with our lecture, I'd like to go over 3 important concepts related to hormone regulation in general. So the first one is that regulation of most endocrine systems takes place at multiple levels of command. And this is what we call an axis. So it's controlled via negative feedback loops. So when investigating an axis, you must evaluate all pertinent levels of this at the same time. And this usually helps us classify endocrine disorders into primary or secondary disorders. I'll give an example here. So when we have hypothyroidism, hypothyroidism can be either primary or secondary, depending on what hormones are affected. So the hypothalamus produces TRH, which controls the pituitary, and it produces TSH in effect. And then the thyroid gland produces T4 and T3, which give negative feedback to the pituitary, and we reach a steady state of hormones between TSH and T4. So this, if you have failure at this level, this is what we call primary hypothyroidism. And if we have failure at this level or this level, we call it secondary hypothyroidism. So the second concept is that most hormones are produced in cyclical fashion or circadian rhythm, which is about 24 hours. Some are more pulsatile with frequent spikes during the day. So it's important for you when you request a lab to know whether this hormone in particular follows a circadian rhythm or not. An example here is the cortisol. The highest surge of cortisol usually is in the early morning hours, and you can see the time here. So we have this high surge around Fajr time, and then the level goes down as the day goes by, reaching the lowest level around midnight, and then you get another surge. So it follows a circadian rhythm. On the other hand, there are other hormones like LH, which follows a signal of GnRH. So each spike of GnRH is followed by a spike of LH. So you can see that these spikes follow each other. So there's pulsatility of the GnRH, which leads to pulsatility of LH. So it's important, again, to understand these mechanisms when you assess a patient in general. So concept number 3, whenever investigating an endocrine problem, start with biochemical screening first, confirming also your diagnosis biochemically, utilizing blood tests, and then proceed for anatomic localization. So we don't mix up usually between blood tests and imaging because we like to confirm our diagnosis biochemically first. This usually eliminates confusion that can happen when you get too much information at the same time. Example here is of a Cushing patient. We know that she has excess cortisol based on the imaging. So we start first with screening tests. Okay, if the screening tests were positive, we go to confirmatory tests. If confirmatory tests were positive, then we order imaging based on the situation that we're dealing with. So we don't start with a pituitary MRI when we still don't have completed our biochemical investigation. So that's the gist of this concept. Like looking at the pituitary cross-section, it is divided into anterior part and a posterior part. The anterior part is called the adenohypophysis and the posterior is the neurohypophysis. The anterior part is where most hormones are produced, and there is some selective distribution. As you can see, growth hormone usually takes up the lateral wings along with prolactin. ACTH and TSH cells are usually in the midline anteriorly. And LH and FSH producing cells are dispersed everywhere. The importance of this in general is that the affection of the pituitary due to tumors does not exert the same effect on all hormones. So in general, when we have a tumor, we expect to lose hormonal function in a sequential fashion. So usually growth hormone is affected first along with LH and FSH. Later on, we might see that TSH is affected, and in advanced cases, you see that ACTH is affected. So there's a form of sequential loss of pituitary function in relation to pituitary tumors. This is normal anatomy. You can see on the sagittal view, this is the pituitary right here, and that's the stalk. It's anterior to the pons, and this is the clivus bone, and this is the sphenoid sinus, the black stuff. So when surgery takes place, they usually go through the transsphenoidal, that's what you hear, transsphenoidal surgery. So the pathway to approach the pituitary is through the nose and sphenoid sinus. So that's a normal pituitary here, that's the stalk, this is the optic chiasm. And the bright spot here is the neurohypophysis, which is usually bright on T1 sequence of MRI. If you look at the coronal view, you can see the cavernous, the internal carotid artery right here. This is the sphenoid sinus. This is the pituitary right here. That's the stalk, and this is the optic chiasm. Now, anterior pituitary hormones have releasing hormones usually from the hypothalamus, starting with gonadotropins, the LH and FSH. They're stimulated by GnRH. And you have the TSH, which is stimulated by TRH, thyrotropin releasing hormone. Prolactin is also controlled partially by the hypothalamus, by the prolactin releasing hormone. Growth hormone is stimulated by growth hormone releasing hormone, also from the hypothalamus. And ACTH is controlled by CRH. Now, each of these hormones goes and affects certain end organs, and these end organs will produce the pertinent hormones, and I'm sure you're familiar with those. Now, the neurohypophysis is responsible for antidiuretic hormone and oxytocin. Oxytocin has very little to do with adult endocrinology. You see it more in obstetrics and gynecology. So ADH is very important for us in endocrinology. Any questions so far? Type. So the pituitary hormones, anterior and posterior, you have the prolactin, the TSH, ACTH, LH and FSH, and growth hormone. And the posterior is the antidiuretic hormone. So what types of pituitary disorders do we face in clinical endocrinology? First and most commonly is the pituitary tumors. And those pituitary tumors make up the bulk of what we see in practice. Up to probably 95% of pituitary problems are related to tumors. And those tumors are 99.99% benign tumors. So you also deal with overproduction or underproduction of hormones related to the cases that you see. Pituitary cancers are extremely rare. I have seen maybe 1 or 2 cases in my career so far. And more commonly, actually, is what we call secondary tumors, meaning metastasis from another site to the pituitary gland. For example, metastatic melanoma, metastatic renal cell carcinoma, metastatic thyroid cancer, for example. We've seen such cases. However, primary pituitary cancers are quite rare. I put craniopharyngiomas here under cancers. It's not a cancer in reality. It behaves aggressively. It's a benign condition usually, but it usually also behaves aggressively with requirement for several surgeries the pituitary function, but it's not a cancer. We see a lot of congenital disorders in pediatrics. Some of those patients require adult care when they grow up. So I do have a couple of those patients with pituitary hypoplasia that are inherited from our pediatric endocrine colleagues. Inflammation is quite rare. 2 examples include sarcoidosis and lymphocytic hypophysitis. Sarcoidosis is an infiltrative disease, a systemic disease. You've learned about it, I'm sure. Rare to see. I've never seen a case of sarcoidosis, to be honest, in the pituitary. Lymphocytic hypophysitis, again, it's another rare condition. We're going to talk about it a little bit in our lectures. Again, it's a rare condition. Infarction, like Sheehan syndrome, can happen, or apoplexy can happen at times. And of course, we have idiopathic hypogonadism, which is also, we're going to talk about it in our lectures. Okay, so pituitary tumors are almost always benign. They're common, and they either produce excess amount of hormones or lead to hormonal deficiency, or both, depending on the situation. What we care about besides hormonal function or loss of hormonal function is local effects like visual field disturbance when the tumor compresses the optic chiasm. Some tumors can cause headaches because of the size, and also cranial nerve compression can be a problem because of big tumors. So that's the coronal view of the pituitary. You can see that this is the optic chiasm. This is the pituitary right here, and this is the sphenoid sinus. This is the right cavernous sinus, and that's the left cavernous sinus. And through it, you see the internal carotid artery. And here you can see some of the cranial nerves, which can be affected by large tumors. So you have the third nerve, the fourth nerve, the fifth nerve, and the sixth nerve right here. So usually this area, whenever the tumor extends to the cavernous sinus, whether on the right side or the left side, it becomes difficult to surgically resect because the surgeon does not want to go to a highly risky area near the internal carotid artery, because any damage to the carotid artery will be disastrous. So usually they try to resect tumors in the midline view of the, while they do the transsphenoidal surgery. And you can look at this image, it's exactly the same. So this is the pituitary right here, that's the stalk, optic chiasm. This black spot on the right and left is the internal carotid artery that you see right here. Okay, so that's what we see on MRI. Cavernous sinus is a small space, not as spacious as you see it here. So the internal carotid artery usually, that's the cavernous sinus. Adenomas are classified by size, and so looking at the size criteria, we say microadenoma for tumors less than 10 millimeters, and macroadenomas for tumors that are more than 10 millimeters. The reason for this distinction is that less than 10 millimeters usually do not reach superiorly far enough to cause compression of the optic chiasm. So when I hear about a tumor which is 8 or 9 millimeters, I immediately expect that it's not compressing the optic chiasm. However, when it exceeds 10 millimeters, it's likely to cause compression on the optic chiasm, and you can see this structure right here, which is the optic chiasm. Additionally, you can see there is lateral extension of the tumor to the left side, and that is what we call cavernous sinus invasion. The tumor is, going into the cavernous sinus. So if this patient undergoes surgery, the surgeon will be able to resect the majority of the tumor, but they will not go into the cavernous sinus because it's a risky area. Okay, so how do we analyze visual field? By using this machine in the ophthalmology department, where the patient puts their head fixed and they see certain blinking lights in the field. Anytime they see a blinking light, they press the button, which is in the hand of this woman. And eventually there will be a map of where the vision is affected. And you can see here there's partial bitemporal myopsia. This is the left eye, and that's the right eye. Now, the types of pituitary tumors, the most common pituitary tumor, depending on the study that you cite, either it's prolactin-producing adenomas or non-functioning adenomas, depending on the reference that you use. Less commonly, you see gonadotroph, which is usually lumped with non-functional. The gonadotroph adenomas are lumped together. ACTH adenomas causing Cushing syndrome or Cushing disease make up 10%. Growth hormone and prolactin, so combined growth hormone and prolactin 7%, growth hormone producing adenomas up to 15%, and very rarely you can see TSH producing adenomas. Okay, so let's start with the first type of pituitary tumors, which is the prolactinomas. Prolactinomas, basically, they are pituitary adenomas that produce prolactin. Again, they're the most common secretory pituitary tumor, and they're more common in women. How do they present? Usually, we classify presentation into two parts, how they present in women in reproductive age and how they present in men and postmenopausal women. The reason is that in the reproductive age, the most common presentation is irregular menses. And typically females, whenever they have irregular menses, after 1 month, 2 months, or maybe 3 months, they immediately seek attention, medical attention, and then they get diagnosed at an early stage if they had prolactinoma. Because their breasts are also primed with estrogen, whenever they have increase in prolactin level, they can have actually contrary to what happens in men and postmenopausal females. So galactorrhea is not common at all in men because the male breast is not primed by estrogen, just like the female breast, or unlike the female breast. Of course, infertility can be a reason to discover prolactinomas. The majority of patients or the majority of women in reproductive age, when they present with prolactinomas, that we usually pick them up early on in the course of the disease. And that's why they present with microprolactinomas. On the other hand, men can have decreased libido or erectile dysfunction, fatigue. Most of these complaints are insidious, and men usually relate them to stresses in life or other problems. So they really don't pay much attention until the tumor grows significantly in size. So the most common presentation of prolactinomas in men is in the macroprolactinoma stage. Similarly, in females, the same problem happens because they don't have a period which is not interrupted by hyperprolactinemia. Now, as we said, pituitary tumors can have different effects on the normal pituitary tissue. So if you have a prolactinoma, you have a segment or a population of cells that are working independently and producing too much prolactin. However, these tumors increase in size significantly, compressing normal pituitary cells, and they may lead to deficiency of those normal pituitary cells. Now, how can hyperprolactinemia cause hypogonadism? That happens in two ways. First, the prolactin itself suppresses gonadotrophs because of suppression of GnRH. Okay, so high prolactin suppresses GnRH at the hypothalamus level, basic reduction in LH and FSH, leading to hypogonadism. So if you have a male with prolactinoma, they usually have reduced libido, erectile dysfunction. You check their testosterone, it's low. You check their LH and FSH, and they're also low. Okay, so that's how prolactinoma affects gonadal function. Another way is by direct suppression or destruction of normal cells that are controlling the LH and FSH. So destruction of those cells can lead to hypogonadism. Now, other pituitary hormones can be affected as well by large prolactinomas, and the most common function to be lost is growth hormone function. ACTH and TSH are rarely affected by large adenomas, but we definitely see patients who come with pan-hypopit. And when we say pan-hypopituitarism, it's more than 3 axes affected by the tumor. So how do you diagnose a patient with a prolactinoma? It depends on how they present. Suppose it's a young female who had an interrupted period for 1 or 2 or 3 months or whatever it is, or maybe longer, of course, if the patient did not have access to healthcare. So what you see the patient in the clinic, she complains of irregular periods or absence of the periods. Part of the routine workup in such condition is to order a prolactin level, and then usually that basically gives up the diagnosis. In addition, the patient might complain of inability to get pregnant or galactorrhea. maybe headache and visual fields if the tumor was large enough. Now, the prolactin level is very important as a number, and I need you to remember this. Microadenomas are usually do not produce a level of prolactin more than 200. Microprolactinomas do not usually produce prolactin level more than 200. Macroadenomas usually produce levels more than 200. Now, what's the importance of this? The importance is if I see a prolactin level of 150 and the tumor size is 2 centimeters, this cannot be a prolactinoma. So why the elevation in the prolactin level? It's another reason, we're going to talk about it. It's called stalk effect. When you compress the stalk of the pituitary, the inhibitory signal that inhibits prolactin production from the lactotrophs is interrupted. And where does this inhibitory signal come from? It comes from the hypothalamus. So dopamine comes through the stalk to the anterior pituitary and applies brakes on prolactin production. This is how prolactin usually is controlled, by dopamine inhibition. Now, if you have interruption of dopamine inhibition, you will have release of prolactin. And this can be seen, as I said, in non-prolactinomas when they're big enough to compress the pituitary stalk. Now, another important thing to remember, anytime you see hyperprolactinemia, count to 10 before you say this is because of prolactinoma, okay? There are many reasons to have hyperprolactinemia that are not related to prolactinoma. So let's go over these causes. Hyperprolactinemia, which means elevated serum prolactin, can be caused because of physiologic causes like pregnancy, lactation, or people who are treated, or any stage of high estrogen state. Also, medications that increase estrogen like oral contraceptives. Also, stress and pain can cause elevation in prolactin. Pathological causes include severe primary hypothyroidism. And I want to emphasize the word severe, okay? Mild primary hypothyroidism does not cause hyperprolactinemia. It has to be severe. Now, additionally, chronic kidney disease can cause hyperprolactinemia due to a lack of clearance. Chest wall pathology like herpes zoster or nipple pathology can cause also hyperprolactinemia. Sometimes people have eczema in the nipple or something of that sort, which leads to hyperprolactinemia. Drugs, very important. Antipsychotics are important, like Risperdal, which is not an uncommon medication. We have also some codeine can cause it. Verapamil, which is an antihypertensive medication, can cause it. Oral contraceptives, as mentioned. So you have to rule out medications before you jump on a conclusion that you have prolactinoma. Okay, good. So this is just another schematic to talk to you about, to show you the effect of the dopamine inhibition. So you have, this is the breast, and you have the dopamine signal. One second. So talking about the stalk effect, the prolactin is produced based on stimulation of the nipple at the level of the hypothalamus. Basically, it provides positive feedback for the pituitary to release prolactin. So anything that interrupts with the stalk, that's the stalk right here. The inhibitory signal from dopamine, you can see it here, this is dopamine. Any inhibition of the dopamine signal coming to the anterior pituitary will lead to hyperprolactinemia. However, less than 200 as a value. So here, you can see that's the normal pituitary. I'm showing it by my cursor. And the stalk must have been much, much thinner than this. This is a very wide stalk. So what's happening here is that there is an infiltrative disease affecting the stalk itself. It could be sarcoidosis, it could be any other type of infiltrative disease that is affecting the stalk in particular, which will cause the hyperprolactinemia. So this elevation in prolactin is called stalk effect. So this guy has nipple piercing, for example, which is a cause of hyperprolactinemia. Fine. Coming to treatment, how do you treat prolactinomas? So you get a patient with symptoms and signs suggestive of hyperprolactinemia. You investigate the person by doing prolactin level, checking gonadal hormones as well to see if prolactin affected gonadal function or not. If the prolactin level was elevated and the clinical picture is compatible with an adenoma, you ruled out secondary causes for hyperprolactinemia like renal failure, nipple pathology, medications. You ruled out all these secondary causes. You made sure the patient was not in pain when the prolactin level was drawn. Then you can proceed with pituitary MRI to look for an adenoma. If you have a prolactin level less than 200, you would expect a microprolactinoma or a macroadenoma, which is not prolactin producing. So the elevated prolactin is because of stock effect. If the level was more than 200, your expectation should be a macroprolactinoma, because no other pathology will produce high prolactin level beyond 200 if it was not a prolactin producing tumor. So once you diagnose a patient with prolactinoma, whether it's a microprolactinoma or a macroprolactinoma, the initial choice of therapy is cabergoline or dopamine agonist. We use cabergoline. The old generation is called bromocriptine. We don't use it any longer. Cabergoline is much more effective and more tolerable, and it's taken only once or twice a week rather than twice a day like bromocriptine. What should you expect when you treat someone with cabergoline? You would expect normalization of their prolactin level, and you would also expect shrinkage in tumor size. Now, you have to look at the other hormonal deficiencies that the patient has and correct them, except for gonadal function, because sometimes gonadal hormones, especially in microprolactinomas, will correct itself automatically when you control prolactin level. So let's say your prolactin level now is 150, you give somebody cabergoline, and 3 months later, the prolactin level is back to normal. You would expect their testosterone, for example, to go back to normal. Or you would expect this patient to have regular menstrual period after some time because of the restoration of the gonadal function. If it does not get back to normal, that's a different story. We give them some time, additional time of monitoring. And if it does not go back to normal, especially with bigger tumor, which are destructive to gonadotrophic hormones, then we can treat them with replacement therapy. Another example, for example, here is, let's say this was a huge prolactin-producing tumor causing adrenal insufficiency and causing hypothyroidism and all that. You do not expect those axes to go back to normal with normalization of prolactin, because you expect that these axes have been completely destroyed. So it's important to start therapy immediately for those hormones, particularly the adrenal insufficiency hormones, which is basically hydrocortisone and thyroxine for hypothyroidism, central hypothyroidism. Now, what if the patient who has a macroprolactinoma comes with visual field defect? Is there any room for surgery? Essentially, we try medical therapy first for 1 or 2 weeks, and usually patients respond very, very nicely with improvement in visual fields, even on a very short period of treatment. So if you notice that your patient had improved visual fields or improved vision, you don't need surgery. However, if you treat a patient with macroprolactinoma for 2 weeks with dopamine agonist, but their vision does not improve, we usually don't wait any longer, and we operate on them to decompress the optic chiasm. So there is very limited role for surgery, except in those with macroprolactinomas who did not respond favorably after 2 or 4 weeks of cabergoline therapy. Radiation therapy is rarely required in such patients. We only give it to those with aggressive tumor who might have had surgeries and failed the surgery, or they're not responding to medical therapy. So in those cases, there might be some room for radiation therapy. But again, this is extremely rare. This is an example of a giant prolactinoma. You can see the tumor is quite large right here. And you can see after medical therapy how much it shrank in size. So we do see this really good response at times when treating prolactinomas. The definition of a giant prolactinoma is any tumor bigger than 3 centimeters. And you can measure it in any axis you want. So any questions so far?
No, thank you, Doctor.
Okay, so monitoring the effect of treatment, we follow the prolactin level, and one of the goals is to ensure that your prolactin level has normalized, and then we perform an MRI to see if the tumor is shrinking in size or not. Some patients with microadenomas, if you treat them with cabergoline and the tumor disappears completely, you can stop treatment after 2 years. Right. Again, any questions, comments, anything not clear? Okay, so let's move on to the second type of secretory tumor, which is growth hormone producing tumors, and the syndrome is called acromegaly. So growth hormone secreting adenomas account for more than 95% of cases of acromegaly. Actually, this is what we see in clinical practice. I've never seen an acromegaly case which was due to growth hormone releasing hormone, which is from the hypothalamus. But this is what the literature says, that you can see it. I haven't seen it personally. The majority of patients with acromegaly present in the macroadenoma phase, meaning it's a bit advanced in the course of the disease. Microadenomas are seen in about 25% of cases. Why is that delay in diagnosis? Because the symptoms of acromegaly are quite nonspecific. People notice changes in their appearance and they attribute that to aging. They notice changes in their foot or hand size, and they say it's probably because of aging as well. So on average, it takes about 10 years from the first symptom of acromegaly to diagnosis. So an average of 10-year delay. So that's why you see most of those patients presenting with macroadenomas, because the tumor keeps growing on over time. Now, growth hormone excess that occurs before puberty, which basically causes fusion of the epiphyseal plates, leads to pituitary gigantism. So if you have a giant patient because of acromegaly, it must have affected that person before his epiphyses closed, before puberty. Now, like any other tumor of the pituitary, it can be part of multiple endocrine neoplasia 1 or other syndromes, and we're going to talk about that in a bit. Symptoms and signs of acromegaly, I'm not going to go over it. You can read it from any reference book. They're quite common symptoms that you should be aware of. I'm just going to highlight arthralgias are common, and we have to account for that. Excessive sweating is a very important activity marker. People have excessive sweating even without exercise. Hypertension and congestive heart failure and arrhythmia, these are the most common cause of death in patients with acromegaly. So we have to pay significant attention to these. And of course, snoring and sleep apnea are common as well and need to be investigated and treated. And that's because of soft tissue swelling in the oropharynx and nasopharynx in general. This is just an interesting picture over time, patient who developed acromegaly. You can see the changes over decades until he was diagnosed. This is an old patient. And here you can see the large hands. They're described as doughy, just like the dough. It's a doughy handshake. And this is a female who had a change in foot size as well because of acromegaly. This is also of historical importance where before MRIs, before CT scans, people had, or physicians only had X-rays at their disposal. So one of the early signs described related to acromegaly is the thick heel pad, and you can see it on a lateral X-ray. This is the calcaneus, and you have a huge amount of soft tissue in the heel of this patient. But nowadays, we don't do these types of X-rays. They're not necessary. So growth hormone also has many, many effects on the body, mainly growth effects and also glucose-related effects. I'm not going to talk about that to save some time. So how do you diagnose a patient with acromegaly? It depends on how the patient presents. Some patients present with pituitary tumors that was discovered incidentally because they had a CT scan for another reason. Let's say severe headache, they went to the emergency room, they had a CT scan, showed a cellular lesion. They end up with a pituitary MRI with a neurosurgeon at some stage. And the neurosurgeon will look at the patient, see some features of acromegaly, and refer the patient to endocrinologist. That's one scenario. Another scenario, a patient presents with obstructive sleep apnea, heart failure, and then somebody looks at the patient and says, this patient has some features that are coarse. He has obstructive sleep apnea and heart failure. I wonder if it's acromegaly. And they check their IGF-1 and it's elevated. So the diagnosis is established based on physical appearance. So again, it's quite variable and each patient has a unique story. So essentially, whenever you suspect acromegaly or you want to work up somebody for acromegaly, the best test is IGF-1, insulin-like growth factor 1. So it's the single best test for acromegaly. It makes the diagnosis without the need for anything else if the patient had acromegalic features. So IGF-1 plus acromegalic features makes the diagnosis of acromegaly, and there's no need to do anything else to reach a diagnosis. However, you're going to do an MRI to look at the tumor and all that stuff. But I'm saying reaching a diagnosis, you don't need more than IGF-1 in a patient with acromegalic features. In some patients with pituitary tumors and little suspicion for acromegaly, you can check the IGF-1, of course, which is very important. It's part of the investigations. And if you find it was elevated, then you need to have elevated growth hormone as well. However, growth hormone level is a bad test in general. Why? Because it fluctuates significantly. As mentioned earlier in this lecture, I had some hormones, and it's affected also by other things like exercise or eating certain foods. Can you hear? I'm having a signal, weak signal. So let me know if you can hear me, please.
So can you repeat last point?
Sure. So in general, a test, you can order growth hormone as a test, but it's not a great test to diagnose acromegaly because it fluctuates significantly. So it increases with exercise, it increases with certain types of food, and it's also high at night and low during the day in general. So we usually measure it as a supplemental or complementary test. The most important test in patients who have elevated IGF-1 but do not have clinical features of acromegaly is to do the growth hormone suppression test. Normally, glucose suppresses growth hormone secretion. So if you eat something sweet, you expect your growth hormone to be suppressed. This is normal physiology. However, in patients with acromegaly, even if we give them 75 grams of glucose load, they do not suppress their growth hormone because of the autonomous production of growth hormone by their pituitary. So if you have a non-suppressed growth hormone after a glucose load, this is considered a positive growth hormone suppression test. And that is the confirmatory test for acromegaly. So acromegaly, you can say, has a screening test, which is IGF-1, and the confirmatory test, which is growth hormone suppression test. And once you diagnose and confirm the diagnosis of acromegaly, you go to imaging. Okay, we don't do imaging before we confirm the diagnosis. So here, a pituitary MRI is sent to tell us more about the tumor. It could be microadenoma or macroadenoma, depending on the situation.
Doctor, could you please repeat the last point? You kind of cut off.
Okay. I'm saying that after confirming acromegaly by doing the IGF-1 level and confirming the diagnosis by growth hormone suppression test, we do a pituitary MRI to look at the tumor size. Now, of course, whenever you diagnose a prolactinoma, you order all the labs related to the pituitary. Whenever you diagnose a patient with acromegaly, you order all the remaining labs related to the pituitary, because as we said, some of them can be high, some of them can be low in relation to the primary diagnosis. So it's not only the growth hormone axis, that we have to look at all of the axes of the pituitary in general. Like, additional important tests include visual field testing for those with macroadenomas. In patients with acromegaly, we need to look at their thyroid, because there is a high incidence of thyroid nodules and thyroid cancer in those patients. We need to do an echocardiogram, because those patients can have hypertension and left ventricular hypertrophy, or heart failure because of acromegaly. So we need to establish a baseline, and we repeat it every once in a while. And of course, we need to do colonoscopy for patients who are diagnosed with acromegaly, because of the high incidence of colon cancer in these patients. So these are complementary studies that we do after we finish dealing with the acute problem of the patient. In the initial few visits, we have to ensure that all of these tests are done. Right. So now we have a patient who is acromegalic with clinical features of acromegaly, who has obstructive sleep apnea and heart failure, very high IGF-1 level. So we did not have to do a growth hormone suppression test. We did an MRI, and we found that the patient has a large pituitary tumor compressing the optic chiasm and invading the right cavernous sinus. How do we treat this patient? So the primary treatment for acromegaly is surgery. Okay, so this patient needs to have surgery. The surgeon will attempt to resect the majority or the whole of the tumor if possible. In macroadenomas, the chance of complete cure is not more than 60%. In microadenomas producing growth hormone, the chance of cure is up to 80 or 90%, and it depends on the expertise of the surgeon. So it's very important for you guys not to refer any patient with pituitary tumors to just a regular neurosurgeon, with all due respect to all surgeons, but you have to have a specialist in pituitary surgery, one who does more than 150 surgeries per year, because data is very specific about this point. The more experienced the surgeon, the higher the cure rate. So there is a direct correlation between the expertise of the surgeon and the cure rate, and you just want it to be done in one shot. The best shot you have at curing this patient is the first surgery. So we usually send the patient to a specialist in pituitary surgery. Now, if cure was not achieved, we have medical options, medical treatments that we can use. And how do we know if cure was achieved or not? We monitor IGF-1 level, because IGF-1 level should go back to normal if the patient was cured. However, IGF-1 takes a long time to come back to normal because of its half-life and clearance. So don't check IGF-1 before 3 months after surgery. Otherwise, it can be falsely elevated and you think that the patient is not cured. So check IGF-1 after 3 months. If it's normal, then your patient is cured. If it's not normal, revert to medical therapy. The first type of medical therapy is somatostatin analogs, which is octreotide. We have also lanreotide, which is very similar, but it depends on the availability of the drug. Dopamine agonists like cabergoline can have some effect, but it's a weak effect. So don't put a lot of hope on cabergoline normalizing IGF-1. Additionally, we have growth hormone receptor blocker like pegvisomant. And finally, we may revert to radiation therapy in those patients who are not surgically cured and not medically controlled. So my goal as an endocrinologist is to have the patient cured from the first surgery. If that was not possible, I want them to be controlled by any of the medications listed in front of you. If I fail to control them, even using several medication combinations, I may revert to radiation therapy. So what improves after cure from acromegaly? Hypertension improves, diabetes improves, soft tissue swelling and obstructive sleep apnea improves, excessive sweating will also improve, but bony changes and large feet and large hand, spacing between the teeth, this and osteoarthritis, This usually does not improve, and the patient has to treat it symptomatically. Life expectancy for cured patients is just like general population. But in untreated patients, there is increased risk of mortality by 2 to 3 times because of cardiovascular disease. Any questions so far? So the group is either, mashallah, yani super attentive and they know their stuff, or you guys are sleeping. So any question?
No, thank you, doctor.
No, thank you.
Doctor, I have a question.
Go ahead.
How common is this or growth hormone tumors in Saudi Arabia?
Acromegaly is estimated to be around 1 or 2 cases per million. It's quite rare.
Thank you, doctor.
Sure. What else? Any other questions on treatment, on diagnosis? Fine. Okay, so let's move on. The third secretory pituitary tumor is called Cushing disease. And what's the difference between Cushing disease and Cushing syndrome? Cushing syndrome is the bigger umbrella, which means it's hypercortisolemia due to any cause. However, Cushing disease is a very specific diagnosis, which is Cushing syndrome due to pituitary tumor producing ACTH, okay? Type signs and symptoms, I'm not gonna go over it. You guys should look it up and you should be very familiar with it. These are the wide red to purple stria on the abdomen. You see it under the armpits or in the thighs. The Cushingoid facies, which is moon face, supraclavicular fullness, dorsocervical fat pad, acne, plethora in the face, which is redness of the face. These are all important signs of acromegaly. Symptoms include fatigue, other things. So how do patients present usually if they have Cushing syndrome? Sometimes a physician picks up Cushing features right away. And that's really an astute physician picking up Cushing features. However, Cushing features are not very different from obesity and diabetics and apathic older patients. So there's a lot of overlap in general between Cushing and other conditions that we commonly see in our practice. And Cushing is quite rare. However, one of the important signs to look for is the plethora on the face. So you sometimes can see moon face in many patients who do not have Cushing, but plethora on top of it, which is the redness of the face, is a strong sign suggestive of Cushing syndrome in general. You get also a fair share of patients with uncontrolled diabetes or uncontrolled hypertension who were worked up for secondary causes of these conditions, and Cushing was diagnosed. Sometimes significant obesity with some suggestive clinical signs will lead you to a diagnosis. Sometimes adrenal adenoma and workup confirms Cushing syndrome. We're going to talk about that later in the adrenal lectures. Sometimes you have osteoporosis in a young female, which is unusual. So you dig deeper into it and you discover Cushing syndrome. And sometimes self-referral, a patient basically diagnosed herself or herself based on Google search. It's not uncommon these days. People really look up a lot of their symptoms and consult medical references online to come up with a diagnosis, and they come to you saying that I have Cushing, and try to convince them otherwise if you're really good. So how do we test once we have clinical suspicion of Cushing syndrome? I want you to concentrate here, please, because this is important. When you investigate Cushing syndrome, start with screening tests, okay? And we're going to talk about 3 screening tests. I don't want any one of you working up Cushing syndrome with advanced or complicated testing. Any patient with Cushing syndrome, suspicion of Cushing syndrome, start with screening tests. The screening tests are 3: 1 milligram dexamethasone suppression test, And don't tell me about the 8 milligram suppression or the 2 milligram 48-hour suppression. Just remember the 1 milligram overnight dexamethasone suppression test, because that is a screening test. The rest are different purpose. The second screening test is the midnight salivary cortisol, and the third one is 24-hour urinary free cortisol. So here you collect urine for 24 hours and measure cortisol. If it's above the normal, that's a positive screening test. Here, if you have elevated midnight salivary cortisol, you give a tube to the patient and they collect saliva at midnight. Usually, because the cortisol is a circadian hormone, it should be the lowest at night and the highest in the morning. So if you have elevated midnight salivary cortisol, this is a positive screening test. And salivary cortisol is a fraction of serum cortisol. Okay, so we all have cortisol in our saliva in a constant relationship with serum cortisol. So that's why we use saliva, because we don't want to, or we cannot, take a blood sample from the patient at home. That's why we use saliva. So these are 3 screening tests. You have to have 2 out of 3 positive screening tests to move on to the confirmatory test. What about the next step? After you have 2 positive screening tests, you move on to measure ACTH. Now, ACTH level can distinguish between ACTH-dependent Cushing syndrome versus ACTH-independent Cushing syndrome. So now I want to hear from the audience. Who knows of a type of ACTH-dependent Cushing? Give me an example of an ACTH-dependent Cushing.
Where it originates in adrenal cortex?
No, adrenal is ACTH independent. يعني the ACTH is not the driver. يعني the ACTH is low. When I say ACTH dependent, it means that the ACTH is high.
Pituitary adenoma?
Yes, pituitary adenoma, صحيح. And
some lung cancers.
Ectopic. بالضبط. Ectopic Cushing. Okay, so either ectopic Cushing or pituitary Cushing are those we call ACTH dependent. Adrenal and medication are the ones that we call ACTH independent, because those will cause suppressed ACTH, not elevated ACTH. Right. So here, if you have ACTH-dependent Cushing, as we said, and we have ectopic, and here we have adrenal adenoma, micronodular hyperplasia, or medications, they're not listed here. And we have a group which we call pseudo-Cushing. I don't need you to know about it, but it's seen in major depression patients or patients with alcoholism. So they come to you with a picture of Cushing syndrome, labs suggestive of Cushing syndrome, even screening tests suggestive of Cushing syndrome. But with further testing and further investigation, they're not Cushing. Now, if you want to investigate a patient with Cushing syndrome, the best way, after screening and confirming that your ACTH is high, you're stuck with 2 differential diagnoses now. Is it ectopic? Maybe a tumor in the chest producing ACTH, or a tumor in the pancreas producing ACTH, or is it in the pituitary? The best way to distinguish the 2 from each other is what we call inferior petrosal sinus sampling. And I'm going to show you something about it later on. So you can do a pituitary MRI to look for a tumor. You can do a CT chest to look for a chest tumor, to try to distinguish between these 2 types of ACTH-dependent Cushing. CT adrenals is for non-ACTH-dependent Cushing.
Doctor?
Yes.
So we only the only case that we say the patient have a Cushing disease, not syndrome, is when the origin is the pituitary gland.
صحيح.
Right?
صحيح. Yes.
Okay.
This has historical implication. Harvey Cushing is a neurosurgeon who described Cushing syndrome in 1927. So that's why the disease is called after him. And that's why we use this terminology, Cushing disease, Cushing syndrome. It's of a historical value, but nowadays, we still use it, but it's just one of those peculiar things in medicine. Type inferior petrosal sinus sampling. You can see this patient on the intervention radiology table. The axis is from the femoral vein, and the radiologist will insert a catheter through the internal jugular vein to the cavernous sinus. On the right side, this is the pituitary right here, and he will insert another catheter on the other side into the petrosal sinus. This is what we call the inferior petrosal sinus. And that's when the radiologist will take samples from the right side and the left side, measuring ACTH level and comparing those numbers with ACTH drawn from a peripheral cannula in the hand of the patient. If you have higher gradient in the petrosal sinus, meaning high ACTH in the petrosal sinus compared to peripheral ACTH, this confirms a diagnosis of Cushing disease. Tamam? If you have equal levels of ACTH from here and the peripheral, this confirms the diagnosis of ectopic Cushing syndrome. Some other considerations related to Cushing syndrome. Sometimes it's associated with hypokalemia, but hypokalemia is much more common in ectopic Cushing syndrome compared to pituitary, which is found in about 10% in patients. Males are much more likely to have Cushing disease, ectopic Cushing compared to female. Yani if you have a female with ACTH dependent Cushing, 90% chance before you do any test, it is pituitary, and 10% chance it is ectopic. However, in the males, ectopic is more common. So it's probably 60% pituitary, 40% ectopic. So what's the most common cause for Cushing syndrome? Iatrogenic. That's the most common cause of Cushing syndrome. It's basically medications prescribed by physicians for immune suppression and whatsoever, or whatever other indication. So here you can see a pituitary MRI with hypoenhancing lesion on the right side. And that's a microadenoma causing Cushing. And here you can see a large tumor, which is a macroadenoma causing Cushing. So the chance of cure in this patient is, again, up to 80–90% surgically. And the chance of cure in this patient is much less in general. Ectopic, you can see some tumors here. For example, in the chest X-ray or CT scan, you can see those neuroendocrine tumors sometimes, or small cell lung cancer at other times. Now, this is a huge adenoma in the adrenal gland, but this is an ACTH independent Cushing. If you see this huge tumor, which is producing too much cortisol, your ACTH is suppressed. Just like the medications, if you give somebody too much steroids, they will suppress their ACTH. So medications and adrenal tumors are causes for ACTH independent Cushing syndrome. How do we treat patients with Cushing disease? You treat them surgically. Here I listed all the types of treatments. So pituitary, you go for transfemoral surgery. Ectopic, you try to localize the tumor first, whether it's in the pancreas, or in the lungs, and you do tumor resection. Adrenal, if it's non-ACTH dependent, you do adrenalectomy. And if there is no focus or other conditions, you can do bilateral adrenalectomy to get rid of the tumor. Sometimes, I'll tell you, in practice, we have a lot of patients with pituitary Cushing syndrome, or Cushing disease, who underwent transfemoral surgery and they're not cured, and we put them on medical therapy and they're not cured, and they're really suffering because of this disease, which is tough to control medically. We sometimes send those patients for bilateral adrenalectomy. If you remove both adrenal glands, then you don't have cortisol production. Your ACTH will remain high, and you will continue to have a large tumor somewhere in the pituitary, but at least the effects of the cortisol on the body are eliminated, which is a big advantage. I'm going to skip these slides. This is a quick story. Two twin sisters, one of them developed Cushing syndrome and she underwent surgery. But many years down the line, she had this ptosis on the right side. Sorry, this patient actually underwent bilateral adrenalectomy. Many years down the line, she comes with this bronze skin discoloration and ptosis of the right eye or the right eyelid. And you can see mydriasis also, so that's Horner syndrome. And you can see on the CT scan, there is an enlarged tumor in the cellular area. And this is the ACTH producing tumor. So this patient initially had Cushing disease, and she was not cured surgically. And she was suffering from Cushing syndrome. So they elected to do bilateral adrenalectomy. And when they did that, she improved, but the tumor itself, the one producing ACTH, started growing very rapidly. And because of the high ACTH level, she has this bronze tone of the skin and this ptosis in the right eye. And this is after resection of the tumor, another surgery that she had it for resection of the tumor, and she improved. But you see that she remains bronze in color, or tanned, yani. So this is what we call Nelson syndrome. Nelson syndrome. Now, medical therapy for Cushing disease include ketoconazole, which is an antifungal agent, but it also inhibits or blocks the production of cortisol in the adrenal gland. I have many patients on ketoconazole now because they're not cured because of Cushing disease. And we have pasireotide, which is somatostatin analog, and it blocks somatostatin receptor 5 in particular. So that's another medication that is given once a month. Or mifepristone, which is a cortisol receptor blocker. You might have heard of mifepristone with the gynecologist because they use it to induce abortion. But in endocrinology, it's used in higher doses to block cortisol receptors. And it basically improves Cushing syndrome. Finally, I'm going to talk about TSH-producing adenoma, and then we're going to take a break before our next lecture. So TSH-producing adenoma is the least common among of all secretory pituitary tumors. Essentially, you have a patient with hyperthyroidism, elevated TSH, and elevated free T4. The patient presents with the regular picture or the regular symptoms and signs of hyperthyroidism that you're aware of, or you will be aware of in the next lectures. And they also have a goiter because of the stimulation from the pituitary by TSH. And it's often mistaken for Graves' disease. Yani this disease can sometimes be mistaken for Graves' disease, which also gives similar pictures except for the eye symptoms. But you have to distinguish between the two, really. It's quite uncommon. I've seen maybe 2 patients at KFSH who have TSH-producing adenomas amongst the hundreds and hundreds of patients with pituitary tumors. So investigations, you will find elevated free T4, or T4 if you want, and inappropriately elevated TSH. So both TSH and free T4 are elevated. Now, to distinguish between TSH-producing adenoma and thyroxine resistance, there is a rare genetic disease which is called thyroxine resistance syndrome. Alpha subunit can be measured. It's a blood test, and it's elevated in TSH-producing adenoma. If you remember, TSH, LH, FSH, and HCG, these 4 glycoproteins are composed of 2 subunits, alpha subunit and beta subunit. The beta subunit is very specific to each of those hormones, but the alpha subunit is a shared subunit among the 4. So if you measure alpha subunit, you will find it to be elevated because the pituitary is inefficient in producing TSH and combining the alpha and beta subunit inside the pituitary, inside the pituitary cells. The pituitary cells that produce TSH, they're inefficient because they're tumorous, and they release a lot of the uncombined or unformed molecule. So you can see alpha subunits and beta subunits in the circulation, and we measure alpha subunit as a marker for this condition. So MRI will show you a pituitary adenoma in this case. So here is the example I just discussed with you. In the blue is the alpha subunit, and the green is the beta subunit. And when they're conjoined together, they make up the one of these 4 hormones, depending on the beta subunits, the specificity of the beta subunit. But those all share the same alpha subunit. So how do you treat a patient coming with TSH-producing pituitary adenoma? Essentially, it's surgery. And if surgery was not curative, somatostatin analogs or octreotide is the is the medication of choice for failed surgery. طبعا, keep in mind that surgery, failed surgery does not mean the end of it. You can really operate on the patient later on, maybe after a year or 2 years, if the tumor grew in size and the surgeon has a good feeling about better resection this time. You can definitely offer the patient another surgery. We have patients who underwent first, second, and third surgeries for some conditions. Yeah. With that, I will end, and I can take some questions before we start with the next lecture. And if you want a break, I'm more than happy to give you a break as well. Any questions?
Doctor, we will have a break for 5 minutes, صح?
If you like, sure. Yani, when do you want us to come back? 2:20?
Yeah. Yes. Yes.
What do you have after my second lecture?
We have a pharma lecture.
Oh, okay. So,
5-minute breaks.
خلاص 5-minute breaks. يعني 2:16 inshallah we can start.
Okay, great. Thank you.
Sure. Okay, are we all back? Should we start?
Yes, doctor.
طيب. So how many are with us الآن? 178. Okay. طيب. ما شاء الله, it's a huge number. بس where is the interaction? طيب. Don't you guys miss the old days? والله we missed them صراحة. طيب. Anyway. السلام عليكم.
عليكم السلام دكتور.
صحيني يا جماعة والله يعني I'm doubting myself شوي.
Yes, doctor, yes.
وين الناس؟ Okay. يلا, let's start with the second lecture. I hope it's not too long, inshallah. It's going to be about 38 slides or so. Type. So the focus of the next lecture is to discuss undersecretion of the pituitary and some other conditions in relation to this problem. Let's see here. Okay. So hypopituitarism is defined as deficiency of one or more of the anterior or posterior pituitary hormones. It's classified into partial or total. Total, we call it panhypopituitarism, and it's usually more than 3 axes. So causes of hypopituitarism can be either congenital. As I mentioned in the previous lecture, some patients have congenital, malfunction or lack of development of either the anterior lobe of the pituitary or the posterior lobe, so a congenital problem. Some patients have acquired disorders, like after a brain concussion, for example, people can lose function of either anterior or posterior hormones. There are many congenital syndromes or genetic mutations that are known to cause different types of hypopituitarism, and we're going to talk about Kallmann syndrome as an example of this category. So Kallmann syndrome is hypogonadotrophic hypogonadism with anosmia. So let's just analyze this terminology. So hypogonadotrophic, okay, which means low gonadotrophic hormones. What are the gonadotrophic hormones? They are LH and FSH. So low LH and FSH causing hypogonadism. What is hypogonadism? It's either low estrogen or low testosterone. So hypogonadotrophic hypogonadism plus anosmia. What is anosmia? Is lack of sense of smell. So Kallmann syndrome has all these features. If you see a patient with hypogonadotrophic hypogonadism, but normal sense of smell, this is not Kallmann syndrome. Now, why do these people have a problem with smell, or what's the etiology of disease? It's failure of the gonadal function due to deficient, we talked about this, deficient gonadotropins. So hypogonadotropic hypogonadism alone is not Kalman syndrome. The reason for Kalman syndrome is failure of migration of the GnRH neurons, and it also affects the olfactory bulbs, which are seen here. Okay, and sorry, those are the olfactory bulbs actually. The arrows show the olfactory bulbs, and these are the olfactory sulci. So if you see a patient with Kalman syndrome right here, you don't see those olfactory bulbs well developed. So the prevalence of Kalman syndrome is 1 in 8,000 to 10,000. So it's not as rare as one might think. Male to female ratio is one. Actually, male is higher. This is a mistake. 5 to 1 rather than 1 to 5. So it's more common in males. However, it is diagnosed also in females. The most common genetic mutation is called CAL1 gene mutation. It's either a mutation or deletion. And this mutation in particular leads to failure of normal migration of GnRH neurons to the hypothalamus. So the hypothalamus is unable to produce GnRH. However, the pituitary has normal LH and FSH cells, but they're not receiving the stimulatory signal from the hypothalamus. So you have failure at the level of the hypothalamus, but the pituitary level and the gonadal level are both intact. If they receive the right signal, they will work properly. So how do these people present? Usually by delayed puberty and primary amenorrhea in females. You can see this male has a longer arm span. So from the tip of the finger, when they extend their arms laterally, tip of the finger to tip of the finger, and compare that to the axial height from head to toe, usually the tip to tip, the arm span, let's put it that way, the arm span is higher than the total height from head to toe by about 5 centimeters or more. This is because of the unrestricted growth of the long bones in the body. Testicular size is less than 4 centimeters, which is pediatric size, infantile genitalia, and lack of body and facial hair. Gynecomastia happens in these kids as well because of low testosterone. And you can see here after testosterone therapy how the body habitus or the morphology of the body changed. The patient has developed penis, pubic hair, less fat, no gynecomastia, and more masculine appearance. Now, other associated factors with Kalman syndrome that you might see or expect is cleft lip or palate, syndactyly, which is fused fingers, unilateral renal agenesis, and also what is called bimanual synkinesis. It's shown in this kid. The video does not work. If he moves the right hand playing with his car toy, the left hand reciprocates the movements exactly. So moving one hand reciprocates the movement of the other hand. He cannot control it as a child, but as they grow, they can control it better. So treatment, how do you treat a patient with Kalman syndrome? First, diagnose them. And when you do the investigations, who can tell me what will be the LH and FSH and testosterone in a patient with Kalman syndrome?
Low.
Go ahead. What will they be?
All of them will be low.
Low, sahih. All of them will be low. Why are they all low?
Because the gonadotropin releasing hormone, which is the neuron that lead to release of these hormones, is not didn't go to the pituitary gland and develop there.
صحيح. So عندك ال GnRH cells are not functioning properly, so they do not produce gonadotropin releasing hormone. So you have low LH, low FSH, and low testosterone. طيب, let me flip the coin and tell you, what if you find a patient with no puberty, طيب, delayed puberty, لكن ال LH and FSH are very, very high, with testosterone is low? What do we call that? Who can answer this question? So again, the same clinical picture, but the LH and FSH are very high and testosterone is undetectable.
The problem is not in the pituitary gland, but I don't know what's the name of the disease.
Okay, well, don't worry about the name. Where is the problem?
In the gonads themselves, testes or ovaries.
صحيح, ممتاز. So the problem here is the testis or the ovary. In our case, it's the testis. So the testis is not able to produce testosterone despite very, very high stimulation from the gonadotropes, which is LH and FSH. So that's what we call primary gonadal failure. Primary. It's more common in females. تمام؟ خصوصا مثل Turner syndrome مثلا. It's primary gonadal failure. Here, what we're talking about is secondary gonadal failure because it's the level of the hypothalamus or the pituitary. طيب, the standard therapy is testosterone estrogen replacement. Sometimes we give them HCG and FSH for inducing fertility. And the non-standard is the pulsatile GnRH. So you guys can ask me, okay, if the problem is not in LH and FSH, can we give them GnRH to cure them? The answer is yes and no. Yes, there is one center in the world that does it in Boston. They give a pump of GnRH. GnRH is a pulsatile hormone. If you give it continuously, you're going to suppress LH and FSH. But if you give it in a pulsatile fashion, you're going to stimulate LH and FSH, and by that you stimulate the testosterone. So there's one center in the US that does that kind of pulsatile therapy. I'm not aware of another center who does it. Fine. So let's move on and talk about non-secretory pituitary adenomas. Okay, so these are tumors that are not functional. They're not growth hormone secreting, they're not prolactin secreting, they're not ACTH secreting, and they're not TSH secreting, okay? So we call them non-secretory pituitary adenomas. They're the second most common type of pituitary adenomas. And because they're not secretory, they present with local or mass effect, either headaches, hormonal deficiency, visual problems, or incidentally found when you're doing imaging for another reason, you discover that this patient has a pituitary tumor. Now, how do you evaluate a patient with a pituitary incidentaloma? They call it a pituitary incidentaloma, and it was not expected. Yani somebody went for a PET scan because they have breast cancer, and the PET scan showed a large cellular lesion. So this is what we call a pituitary incidentaloma. You start by history taking, ask about symptoms of excess or deficiency. طبعا here we're focused more on deficiency. Prolactin deficiency, for example, has no much effect except for failure of nursing woman. TSH deficiency causes hypothyroidism. ACTH deficiency causes adrenal insufficiency. LH and FSH deficiency causes hypogonadism. Growth hormone deficiency causes short stature in kids. Hold on one second, please. Sorry, guys. Type. So we continue. Growth hormone deficiency in adults is not important usually, but in pediatric age, it can lead to short stature. And antidiuretic hormone deficiency can lead to what? Who can tell me what does ADH deficiency cause? Anyone?
A lot of diuresis.
صحيح. What's the name of this syndrome? Diabetes insipidus. تمام? Diabetes insipidus. طيب. So symptoms of mass effect, we mentioned those, either headaches or visual field problems if the tumor is compressing the optic chiasm. طيب, how do you examine a patient with a non-secretory tumor? If they might have some features, but not too many. In males, in general, if they're hypogonadal for a long time, they can have what we call hypogonadal facies, a pale, waxy face with fine wrinkles. It's not easy to distinguish صراحة. But you have also loss of secondary sexual characteristics like less facial hair and mustache and that stuff. You might have central obesity, but that's also common for other reasons. Delayed reflexes, maybe because of hypothyroidism, and small testicles because of hypogonadism. So investigations, as we mentioned, anytime you face a patient with a pituitary problem, you order all the axes, all of them. So prolactin level, TSH, free T4, ACTH, cortisol, LHFH, estrogen or testosterone, IGF-1, and urea electrolytes, because sometimes we can see some electrolyte changes with mainly adrenal insufficiency. And of course, you're going to order a pituitary MRI. Right, so we're going to talk a little bit in details about central adrenal insufficiency, central hypothyroidism, central hypogonadism, and diabetes insipidus. Okay, now a single patient can have many of those conditions. It's not necessary. One tumor will cause one hormonal deficiency. As we mentioned, hormonal deficiencies can be multiple or pan. Pan means more than 3 axes are affected. So if a patient comes to you with adrenal insufficiency, they will have fatigue, weight loss, abdominal pain, nausea, and vomiting. And signs, maybe you can pick up postural hypotension. Patients with adrenal insufficiency are quite tired and fatigued, and they look sick. And so you might see this look on them. Now, how do you test for adrenal insufficiency? We order a baseline cortisol and ACTH. And please do not order labs at night. ليش? Who can tell me why, if we're investigating adrenal insufficiency, we should not order these labs late at night?
Because of the rhythm?
صحيح, في عندي circadian rhythm, so they're expected to be low at night, so don't order them at night. Then if they're low, you don't know if they're low because you ordered them at night or because the patient truly has adrenal insufficiency. Whenever you order a hormone level, order it at the expected peak. So the peak ACTH or peak cortisol is usually in the morning. So you should order them early in the morning. Now, if you order ACTH and you find it low, and you order cortisol and it's also low, this is suggestive of adrenal insufficiency. Is it primary or secondary when both are low?
Secondary.
صحيح. So if I have low ACTH and low cortisol, this is secondary adrenal insufficiency. Now, this is not enough on itself or by itself to diagnose somebody with adrenal insufficiency. We have to do what is called an ACTH stimulation test or synacthin test. How do we do it? We obtain a baseline cortisol level, and we inject the patient with 250 micrograms of ACTH analog, or cosentropin ism medication. You give it either IM or IV, and then you obtain another sample at 30 minutes and 60 minutes. And we're all what is measured here is cortisol. So cortisol at 0 minutes, cortisol at 30 minutes, and cortisol at 60 minutes. The 30 and 60 are following ACTH injection. What you should see in normal patients is a sharp rise in cortisol level if they have intact adrenal axis. Patients with primary or secondary adrenal insufficiency will have a flat response. The baseline is similar to the 30 or 60 minute level. So that's a normal ACTH stimulation test, which confirms your diagnosis. How do we differentiate between primary adrenal insufficiency and secondary adrenal insufficiency? I need one sign and one lab test. The distinction between primary adrenal insufficiency and secondary adrenal insufficiency.
On lab, not both of them will be low. So one will be normal and one will be low.
Which one will be normal? And what test are you referring to?
ACTH will be high or normal.
خلينا نعتبر high. Let's put it that way. You're right. So ACTH will be high, صحيح. And what will be low?
Cortisol.
Tamam. So you have high ACTH and low cortisol. This picture is suggestive of primary adrenal insufficiency. The pituitary is sensing deficiency of cortisol. And in response to that, it's producing a lot of ACTH, trying to stimulate and stimulate and stimulate the adrenal gland, but it's not responding, so it keeps stimulating. So the ACTH must be very high. Tamam? Because of the high ACTH, what clinical finding you will see in that patient? What characteristic feature of Addison disease because of the high ACTH level?
Water retention.
أحكي على sign, something you see the patient, unmistakable, you see it in front of you. Those patients are very tan in color. They're hyperpigmented. ليش؟ لأن the precursor to ACTH is also gives us a molecule melanocortin. ما اسمه كان melanocortin? So basically, it's a melanin inducing substance that is produced because of the very high ACTH. So the precursor of ACTH also affects the pigmentation of the skin. So those patients have hyperpigmentation. In secondary adrenal insufficiency, they don't have hyperpigmentation. So the level should be above 500 when you do the ACTH stimulation. The level of cortisol should be more than 100, either 30 or 60 minutes. Previously, we used to do the insulin tolerance test. I want to talk about it. It's or maybe I can tell you about it. Basically, if you stress the body or the patient, they should raise their cortisol, regardless of what type of stress. So in the past, we used to use insulin. We induce hypoglycemia intentionally. And we give the patient big doses of insulin to cause hypoglycemia. And they feel hypoglycemic, they're sweating, they're tremulous, they're tachycardic. And then you measure their cortisol level. If the cortisol level was high, this means that they are responding normally to stress. So they don't have adrenal insufficiency. If their cortisol was low, that means that they have abnormal adrenal response. Okay, we don't use it any longer nowadays. When I was a resident, we used to do it, but not anymore. Next is treatment. How do you treat central adrenal insufficiency? We treat it with steroids. We give them 10 milligrams in the morning and 5 milligrams in the evening. We're trying to mimic circadian rhythm. You need cortisol much more in the morning and less in the evening. Sorry, I don't know what happened here. Okay, so let's move on. Okay, so now there is no need for giving those people the other adrenal hormone, which is mineralocorticoid or aldosterone, because that is controlled by a different axis, the aldosterone axis. Now, if they have any sickness or illness, they need to double the dose of steroids. And this is very important because we normally, when we get sick or febrile, we increase cortisol. They cannot do that because they depend on cortisol coming from outside. So they have to double their cortisol or their hydrocortisone for a few days when they get ill. So these are medical alert bracelets, which people are encouraged to wear. They can buy it by themselves from pharmacies, and they inscribe on it adrenal insufficiency. So the paramedics, if they find them in any situation unable to help themselves, they would immediately give them an injection of steroids, which can be life-saving. Moving on, we covered adrenal insufficiency and how to diagnose it and how to treat it. If you have a patient with central hypothyroidism, symptoms are fatigue, weight gain, cold intolerance, and constipation. They're not very different from primary hypothyroidism. And you can see delayed reflexes on physical exam. In this case, their TSH and free T4 are both low, okay? Now, what do you see in Hashimoto thyroiditis, for example? Primary hypothyroidism, you see that the TSH is very high, but the free T4 is low. So that's how we distinguish between primary and secondary hypothyroidism. Hashimoto is a cause for primary hypothyroidism. A large pituitary tumor or destructive tumor in the cellular area is a cause for secondary hypothyroidism. So the treatment is levothyroxine. We usually give it based on their weight, 1.6 micrograms per kilogram, and then you adjust the dose based on the labs. I did not mention that we don't have a good lab test to tell me if my patient is adequately controlled with steroids. Again, we do not have a good test to tell me or to monitor the therapeutic effect of hydrocortisone in patients with adrenal insufficiency. We don't have any lab of that sort. But we do have labs that can tell us if the patient is adequately replaced with thyroxine in case of primary hypothyroidism or secondary hypothyroidism. In primary hypothyroidism, like Hashimoto, for example, I measure their TSH. Initially, when I made the diagnosis, it was very high. And after that, after I treat them, it should come back to normal. In patients with central hypothyroidism, I cannot depend on their TSH. I know it's to start with, it monitor with the free T4 level. I give them thyroxine to ensure that the T4 level goes up to the normal value. Now, whenever you have a patient with combined adrenal insufficiency and hypothyroidism, always start with adrenal hormone replacement first and then give thyroxine. This is the general rule to avoid Addisonian crisis. What about growth hormone deficiency? This is the third axis that we're talking about. Growth hormone deficiency in general has very non-specific signs in adults, symptoms and signs in adults, but in kids, it's very children with growth hormone deficiency of short stature. Okay, and it's a very common presentation for pediatric patients to present with short stature. I'm sure you probably were exposed to investigating short stature in your other courses. It's a very common pediatric problem. There are many reasons for short stature. One of them is growth hormone deficiency in kids. In adults, growth hormone deficiency is not very important. I have a lot of patients with pituitary tumors, none of which right now is on growth hormone replacement therapy. No, you replace the other deficient axes and they feel perfectly fine usually. Okay, type. So what are the signs of growth hormone deficiency? There are no specific signs. How do you test them? You do IGF-1 level, which is typically low. But if you really want to diagnose it, you have to do growth hormone stimulation test, which is out of the scope of this lecture. How do you treat it? طبعا the stimulation test is either insulin tolerance test. Okay, we have a nice graph here actually. So let's talk about it. These open circles are glucose levels, and you can arrow here is the insulin. So at a level of glucose, maybe the normal glucose of the patient was, let's say 90 fasting, you inject insulin and you drop their glucose below 40 milligram per deciliter. So once they drop their glucose, this is a stressful situation for the body. Stress will induce both growth and cortisol. So if you look at the rectangles, you can see that the plasma cortisol level was less than 10, for example, and it basically rises significantly with the hypoglycemia. And you can see also in these triangles, the growth hormone was here and you stimulated it sharply with induction of hypoglycemia. So this is one type of stimulation test that is used for either stimulating the adrenal or stimulating the growth hormone axis. طبعا insulin tolerance test is still used nowadays for growth hormone deficiency testing in children. More testing like glucagon stimulation test is available now, which is a bit safer than insulin tolerance test. Type. So growth hormone deficiency treatment, limited efficacy, very few adults with growth hormone deficiency require treatment. Benefits of treatment may include improved bone mineralization, exercise capacity, muscle mass. It can reduce body fat, but not to the degree that you might think, or the patient might think, and improve quality of life. The problem is it's very expensive and it's a daily subcutaneous injection. So again, another reason for not opening that door in general. You monitor the efficacy of treatment by measuring the IGF-1 level. طبعا growth hormone is a hormone that induces growth of tissues, and it will do the same for cancer tissue. So never give growth hormone for a patient with active cancer. Similarly, testosterone therapy, يعني الشيء بالشيء يذكر, just as a reminder, prostate cancer grows on testosterone. يعني testosterone is the fuel for prostate cancer. However, testosterone does not cause prostate cancer, but those with prostate cancer should avoid testosterone therapy. And in reality, urologists or oncologists treat those patients with anti-testosterone drugs that really decrease their testosterone to zero so that they can control the cancer. طيب, moving along to diabetes insipidus. People with diabetes insipidus, the true diabetes insipidus are quite easy to pick up. They're always walking around with a bottle of water, and they drink from this bottle of water several times during their clinic visit, and they get excused from the clinic visit a couple of times also to go to the bathroom and pass urine. So these people are really suffering because of polyuria and polydipsia. You can see here on the sagittal view of a normal pituitary, there is absence of a posterior bright spot. I showed it to you in the first lecture. This also is one of the radiological features of absence of ADH, antidiuretic hormone. So this patient, for example, does not have a pituitary tumor, but has only absence of this bright signal. And if that person has DI, it could be due to any reason like a brain injury or concussion or something that caused diabetes insipidus. So not necessarily a pituitary or a cellular tumor. So diabetes insipidus results from deficiency of antidiuretic hormone. It's encountered in two settings: after pituitary surgery as a complication because the surgeon manipulated the pituitary and severed maybe the stalk or something. Usually it's transient and resolves spontaneously in a couple of days after the surgery, but sometimes it's persistent and requires long-term therapy. Another cause for diabetes insipidus is due to stalk conditions. I showed you an example previously of a stalk infiltrative mass that caused hyperprolactinemia. And we said that prolactin level does not exceed 200 at that stage. Well, the same thing happens also where stalk lesions can cause diabetes insipidus because the antidiuretic hormone comes from the hypothalamus through the stalk to the posterior pituitary. So anything interfering with that flow of hormones through the stalk will cause diabetes insipidus. Famous example of tumors known, very, very well known to cause diabetes insipidus are craniopharyngiomas, and I need you to remember this. Lymphocytic hypophysitis is another condition that can cause diabetes insipidus, and apoplexy, which is infarction of a pituitary tumor, can cause diabetes insipidus. Large pituitary tumors, large adenomas in particular, are not familiar or not commonly a cause for diabetes insipidus. If I see a relatively small tumor, for example, I'll tell you how I use this clinically. If I see a 1 or 2 centimeter lesion in the pituitary, and I see diabetes insipidus, I'm quite confident that this is not an adenoma. It must be something else. It could be craniopharyngioma, it could be meningioma, or any other pathology. Right. How do you diagnose diabetes insipidus? Mainly history and physical, and the context of the patient. If I see somebody 2 days after transsphenoidal surgery for a pituitary tumor and he has polyuria and polydipsia, it's clear cut. This patient, why and how they have diabetes insipidus. I don't even need to test them. I know it's very clear in the context. However, sometimes you get referrals from other sections or other specialists for polydipsia, a patient who drinks a lot of water out of nowhere. And then you have to get this patient, see them in clinic, take full history, do proper exam, and see what might the reason for polydipsia is. It can be diabetes insipidus, it can be primary polydipsia or psychological problem or nephrogenic diabetes or other things. So the diagnosis of DI depends on the context, history, and physical. Polyuria is defined as more than 3 liters of urine output per day. In the hospital setting, when a patient is post-operative with a Foley catheter, you can always measure their hourly urine output. So if it's more than 250 per hour for 2 consecutive hours, this is abnormal. So you might think of DI. طبعا in the labs, you have low urine osmolality, low urine specific gravity, dilute urine. The patients will tell you, my urine is very, very clear. It never darkens or becomes yellow. And the formal test is the water deprivation test, which we rarely do, if ever, حقيقة. It has its own pathway, and you measure the weight of the patient, because you don't give them desmopressin or the treatment, and you watch them basically as they lose fluids from their body over time. You measure their urine output, you measure their sodium, you measure their weight on every 30 minutes, because these people will lose weight because of the fluid loss. And then you reach a conclusion whether it's DI or not. Treatment of diabetes insipidus, it's by giving the patient antidiuretic hormone or vasopressin, either by nasal spray or sublingual tablets. طبعا if you cure a patient, أو مو cure, if you treat a patient with diabetes insipidus, يعني they will think you're the best physician on earth, لأنه they were suffering صراحة because of polyuria and polydipsia, and now you give them this magical tablet under their tongue, which melts away in seconds and then gives them relief for 12 hours. So it's a major يعني improvement in the patient's condition. طبعا DI, if it happens and it does not resolve after several days to several weeks after surgery, it's unlikely to resolve, so they're going to be stuck with it for life. However, it's treatable. يعني people take that medication twice a day and they feel very, very good. Another medication which has really profound يعني improvement on the patient's well-being is steroids. When you give it to somebody with adrenal insufficiency, they were fatigued, tired, nauseous, losing weight, no energy, and you give them steroids, it really changes their life. So again, drastic يعني transformation with these medications. To summarize, if you have ACTH deficiency, it is adrenal insufficiency, you give them hydrocortisone. If it's TSH deficiency, you give them thyroxine. Prolactin does not require to be treated. LH and FSH, you treat them with testosterone or estrogen. And growth hormone, you treat them with growth hormone if needed. Desmopressin is treated with, antidiuretic hormone deficiency is treated with vasopressin. طبعا we have just a couple of minutes to finish. When to operate on secretory. طبعا when we talk about non-secretory tumors, surgery is indicated because of mass effect, okay? So if there is optic chiasm compression, to operate to save the vision. Sometimes we operate because of severe headache, although it's a flip of a coin in many patients. If you have apoplexy, meaning the tumor bled into itself, we operate surgically, or we treat them surgically. Or if you have recurrence of the tumor, so you resected the tumor now and then it grew in 3-4 years and you resect it again. So sometimes you do that. So here you can see this tumor right here. And after resection, it almost disappeared. That's the optic chiasm. And the tumor was compressing the optic chiasm in this image. Radiation therapy, we revert to it whether for secretory or non-secretory tumors. Number one, if the tumor regrows after surgery, or if the tumor cannot be resected fully, or if the tumor cannot be controlled, يعني the tumor functionality cannot be controlled adequately, like growth hormone secreting tumors, which are not well controlled with surgery and medications, you can offer these people radiation therapy. I also can offer it to patients with Cushing disease or maybe aggressive prolactinomas, that sort of thing. There are two types of radiotherapy, conventional or gamma knife. Yani, I'm not going to go into the details. Pituitary apoplexy is an acute and life-threatening infarction of the pituitary gland or adenoma. Usually it happens in the tumorous part. طبعاً, one example is Sheehan syndrome, and you're all familiar with it, which is infarction of the pituitary because of massive peripartum or postpartum bleeding. It can cause infarction of the pituitary. So those patients will not have symptoms immediately, Most of them are insidious in onset, but they will have panhypopituitarism. So the mother cannot breastfeed, will have adrenal insufficiency, hypothyroidism, irregular periods and all that stuff. So how do apoplexy presents? I just don't want you to confuse apoplexy with Sheehan. So Sheehan is infarction of a normal pituitary in a very specific situation, which is massive postpartum hemorrhage. That is Sheehan syndrome. Apoplexy is hemorrhage into a tumor which is already in the pituitary. I hope the distinction is clear. So the presentation is usually severe headache, visual field defect, cranial nerve palsies because of the expansion of the tumor, a tumor expansion of the blood hemorrhage that's happening in that place, and altered mental status. And here you can see a fluid level. The patient, you have to imagine the patient lying on their back. So that's the back of the exam table or the scan table. So this is a horizontal line which separates the the thin part from the thick part of the blood when it disintegrates. So you can see this horizontal line. So apoplexy in and of itself can cause hormonal deficiencies. So you have to watch out for that and evaluate the patient completely. I think this is the last slide. Lymphocytic hypophysitis, it's inflammation. It's an inflammatory process that affects the pituitary in a selective fashion. We have many inflammatory disorders in the endocrine world. For example, inflammation of the thyroid, you know about Graves' disease, you know about Hashimoto. Inflammation of the ovaries, for example, it can cause premature ovarian failure. And we have also inflammation of the pituitary itself. So inflammation of the pituitary, there is lymphocytic infiltration of the pituitary, which causes hormonal deficiency and diabetes insipidus. The most common scenario is a postpartum woman presenting with polyuria and polydipsia. That's a common scenario, the most common scenario. So diabetes insipidus in a postpartum woman with adrenal insufficiency and a lesion in the pituitary, this is a clear-cut lymphocytic hypophysitis scenario. It can cause also severe headache, and treatment usually is by immune suppression, and we try to suppress the inflammation by giving them steroids. A few words about craniopharyngioma. It's another type of tumors that can affect children and elderly. They're quite aggressive. They have cystic solid component. They can cause deficiency in many hormones, especially diabetes insipidus, and they require several surgeries. Another form of cellular tumor is meningiomas, which is tumor growing from meninges. Again, it affects the cella. It's easy to distinguish based on MRI characteristics. So if you want, you can easily distinguish between craniopharyngioma, meningioma, and pituitary adenomas by imaging. طبعاً the history is important, physical finding is important. With that, I will end. Thank you very much. I can take a few questions if you have any. And if not, we will see you tomorrow, inshallah, for our LGD.
Yeah, Doctor, I have one question about cortisone.
Yes.
What is the level of, when you give a patient a prednisolone, what is the amount or the level that you give it that lead to the osteoporosis? 5 milligrams, grams?
ممتاز. طبعا there is no specific cutoff point. It depends على dose and chronicity of use. يعني somebody on 5 milligram prednisone for 10 years هيصير عنده osteoporosis. Somebody on 40 milligrams of prednisone for 2 weeks ما هيصير عنده osteoporosis. You get me? So it depends on the duration and the dose. A replacement dose that we give for adrenal insufficiency does not cause osteoporosis. And we all have endogenous cortisol. And the treatment we're giving is to replace that endogenous cortisol. So 10 hydrocortisone in the morning and 5 hydrocortisone in the evening. This is not excessive. It's not above what we normally produce. So it does not cause osteoporosis or other issues.
Okay, thank you.
You're welcome. Any other question? طبعا in the sheets I shared with you اللي هي السمري of the lecture في تحت link survey monkey, because don't worry about it. This was for older times. So don't worry about it. Anyway, if you have any questions, my email is on that sheet. You can send me an email. I'll be happy to answer you. And you can ask me anytime, inshallah, during this course. Best of luck and see you tomorrow. Thank you.
Thank you, Doctor.